Dear pure urologists, good evening, one and all. Today is actually a little uncommon subject where the intestinal segments are used for the urethral reconstruction. I correct, not urethral, urethral. We all used buccal mucosa, buccal mucosa, buccal mucosa, and maybe lingual mucosa, maybe skin flap. But here, when they are not available or in certain circumstances, bowel segments also technically can be used, but very few people may be doing in India. That's why we called Dr. Rajesh Rajendran, who is from our South India, and he is well known for his urethral reconstruction injury, reconstruction surgery. So to introduce briefly about sir, today topic is intestinal segment in urethral reconstruction. He is reconstructive urologist, Aishwarya Hospital, Tiruchirappalli. Senior Assistant Professor, Department of Urology, MGM Hospital, KAPB Medical College, Tiruchirappalli. Reconstructive Urology training under Professor Rados, Serbia. International publication and presentations are there. He has many international publications, invited as reconstructive urology faculty in many national and international conferences, conducting periodic training workshops, urethroplasty at Aishwarya Hospital, conducted many state, zonal, and international workshops. First in the world to describe ileal mucosal graft urethroplasty. First in India to do gastro-urethroplasty in MGM Government Hospital, Trichy. First urologist from India to appear for oral presentation for his paper in Imoru, Hamburg, Germany. First in the world to describe an importance of suspensory ligament of penis in hypospadias surgery, along with Dr. Ashish Pardesi, Pune. Second in India to do vascularized ileal pedicle tube urethroplasty. Established transgender unit in MGM Government Hospital, Tiruchirappalli. First in Tamil Nadu to do rectus cystomyopexy for neurogenic bladder. So rectus cystomyopexy for neurogenic bladder. That is good. Dr. Shabir Hussain, who is my classmate, used to talk about this. And I don't know much about this subject. In fact, I'll be learning a lot today, Dr. Rajesh. Thank you once again for accepting the invitation. Now we will give you the control of your presentation. And now this is the presentation. You can go ahead. Thank you very much.
Thank you, sir. Good evening, all. Thank you, Chandramohan, sir, for this great opportunity to be here with you. And my topic is intestinal segments in urethral reconstruction.
Yeah, just 1 second. Yes. Okay.
As far as urethral reconstruction is concerned, we have two components. One is there may be deficiency of the urethral mucosa, especially in patients with inflammatory stricture. In traumatic stricture, the problem may be in the mucosa as well as the surrounding spongiofibrosis. So for the inflammatory stricture, we will be removing the diseased mucosa and replacing with a new mucosa, usually from the oral cavity. And in reconstructing urethra, we have two types of surgeries. We can use only the mucosa instead of oral mucosa, and it can be used as a graft. The other thing is we can use the whole intestinal segment with a vascularized pedicle tube flap. So these are the two types of methods by which we can use intestine in urethroplasty. Coming to the intestinal mucosa graft, we can use ileal mucosa or we can use rectal mucosa, and also sigmoid mucosal graft can be used for urethral reconstruction. The indications for ileal mucosal graft are: if the buccal mucosa is not suitable for harvest, and patients with the pan-urethral stricture with a very thin urethral plate, there you may need lot of oral mucosa to reconstruct urethra. And in patients with the failed buccal mucosal graft, where most probably the pathology is in the buccal mucosa, and this is the reason the urethroplasty has failed. In all these cases, we prefer ileal mucosal graft urethroplasty. So these are the patients where you can see oral cavity is very bad in brittle chewing, lichen planus, nutrition deficiency, patients with submucous fibrosis. And there are very few group of patients where there is lichen sclerosis of the genitals as well as the lichen sclerosis of the oral cavity. In these patients, if you take the mucosa, oral mucosa and urethroplasty, definitely it will fail. So these are the indications where we use ileum instead of buccal mucosa. Here, coming to the technique, through a small Megman's Gridia incision, we will be opening the abdomen and we will be taking 10 centimeter of the ileum. After taking the ileum, the bowel continuity is maintained by doing end-to-end anastomosis. And this resected bowel segment is opened in the antimesenteric border. After opening this, we'll be separating the mucosa from the ileum. This mucosa resection should be done very meticulously and very slowly, especially with the magnifying loops, because the mucosa is very, very thin when compared to the buccal mucosa, and the chance of tearing is very, very high in ileal mucosa. And after taking the mucosa, you can use this for the dorsal ileal mucosa urethroplasty. Here you can see there is only one strip of mucosa from the meatus to the proximal bulbar region. Only one strip of mucosa. So this is the beauty of ileum. And these are the preoperative and postoperative ascending urethral picture just for demonstration and documentation. And this is the case of preoperative panurethral stricture. And this is the postoperative picture of the
It is not playing, sir.
1 second.
No, sir, it's not playing. It's not playing. No problem, sir. Go to next slide. Both from my side and your side, it's not playing.
Okay.
Now, how many years follow up this buccal mucosa, this ileal mucosal graft, sir?
Now it will play.
No, sir, it is coming, cannot play media. It will not play, sir.
Okay.
It will not play even if you press.
Okay. So actually, we did the first case in the year 2008, actually, and we have the longest follow-up, almost 15 years. So we have done almost 62 cases, but the case selection is very important in ileal. As I said, no, the criteria is panurethral stricture with very bad disease and failed cases, and in those patients where the oral cavity is not suitable. These are the cases indication for these cases, and our longest follow-up is almost 15 years. And the results of these ileal mucosa is almost comparable to buccal, and these patients are doing well, actually. The other options are we can use rectal mucosa and sigmoid. We have done only 2 cases of rectal mucosa, and sigmoid we don't have experience at all.
So what is the histological advantage of this intestinal mucosa, sir? Is there any advantage, or it is because you don't have a choice?
So one is we don't have a choice. Second, the mucosa is very thin, actually, and the graft uptake is very good, actually. Even on the table, when you fix the graft, within few hours you can see the mucus secretion is there. That means the graft is taken. The take-up of graft is very, very fast, actually. And after 1 week, you can see meatus, some amount of mucus flakes coming out of the meatus during our dressing. But these patients, they don't complain about any mucus secretion, but when you do scopy, we can see small mucus flakes. So this is the evidence that this graft has taken very well.
Okay.
And coming And coming to the vascularized intestinal tube flap urethroplasty, this we call as urethroplasty. Here the indications are the patients with a long segment urethral loss. This usually happens after, in the case of pelvic fracture urethral injury, after multiple surgeries, these patients will go for ischemic necrosis of urethra. The literature says use the word bulbar urethral necrosis for these patients, but we prefer to use the word ischemic necrosis of urethra. The reason being, in these patients, not only the bulbar urethra is involved. In many patients, apart from bulbar urethra, pineal urethra is also at loss. So we prefer the word ischemic necrosis of urethra, which happens in pelvic fracture patients after multiple surgeries due to the blood loss. And in some patients with traumatic urethral loss, where the whole of urethra is gone, in these patients also we can do this vascularized pedicle tube flaps. Here you can see this is the pineal distal urethral mucosa. This is available only with 3 centimeters. The whole of the pineal urethra and the rest of the bulbar urethra, everything is fibrotic and no tissue is seen at all. So 360-degree loss of the bulbar and the pineal urethra. Here you can see the SPC sound which I passed through the SPC tract, and only 2 centimeters of the mucosa is viable. The rest of the whole region only scar and fibrotic tissue, no lumen at all. So these 2 cases happened after pelvic fracture distraction defect with the multiple surgeries. So in these patients, what we can do, we can reconstruct this portion of the urethra with a segment of the ileum with a vascularized pedicle. First, we'll discuss about the ileal pedicle tube flap. So here we have taken about 12 to 14 centimeters of the ileum with the vascular pedicle, and this segment was brought down, and the proximal end anastomosed to the prostatic urethra, and the rest with the available distal urethra. Here you can see the stapler sutures. We have to reduce the lumen of the intestinal segment, so we use the stapler segments. And this is the ileal mucosal urethroplasty using the vascularized segment. And now then is sigmoid urethroplasty, where you can take a segment of the sigmoid with the vascular pedicle, and this can be brought down into the perineum, and in the same way we can reconstruct the urethra. This is gastrourethroplasty, where just like sleeve gastrectomy, we'll be taking a segment of the stomach from the greater curvature. The vascularity is based on the right gastroepibulloic artery, and this segment is tubularized, and this we can brought down into the perineum. See here you can see the stomach segment converted into the urethral tube. And this is the tube, and this is the reconstructed urethra, and this is the corpora. And this is the postoperative ascending urethrogram picture, where you can see a beautiful urethra, reconstructed urethra with the stomach segment. This is post-operative picture of where we use ileal flap. You can see the mucus plaques. This is the case of sigmoid urethroplasty. This is almost 1 year after the surgery.
Yes, sir.
These are the post-operative pictures, and this is gastrourethroplasty, this is ileourethroplasty, and this is, you can see the sigmoid urethroplasty. Coming to the technical challenge, here the length of the flap pedicle is important factor in sigmoid, ileum, and stomach. In the sigmoid, the vascular pedicle is just near the prostate, and so it is very easy, provided the sigmoid loop is very wide and mobile. The next option is the ileum. This ileum in obese patients is very difficult to do ileum because if the length is short, then we have to release all the 4 layers of the ileum, maintaining only the vascularity, and it has to be brought down. And coming to the stomach, the mobility is very easy because it is based on the right gastroepiphytic artery. The mobility is very high, and we can bring very easily the stomach segment. But each of the surgery has their own complications, and the least complication is happening in the sigmoid. So in the gastrointestinal segment, sigmoid will be the first choice, so ileum will be the second, and third will be the stomach. The other problem is how we bring the flap into the perineum. One approach is we can bring it through direct subcutaneous suprapubic approach. This is one option. Second option is we can create a trench in the suprapubic ramus bone. We can create a trench, and through the trench we can bring the bowel segment into the perineum. Third is in some patients where there is pubic diastasis, we can even go through the perineal route. And totally in the stomach we have done 10 cases, and ileum 10, and sigmoid 2 cases. And this is a case of this is acid matritis which happened after gastrourethroplasty. This is one of the expected complication after gastrourethroplasty because of acid secretion. The take-home message is enterourethroplasty using the graft considered in all cases of patients with poor oral cavity. And coming to the flaps, it is indicated in patients with long segment urethral loss after multiple surgeries. And the catastrophic complications of bowel anastomosis should always be kept in mind. And vascularized tube enterourethroplasty is not for the beginners. Unless you are very comfortable with the failed cases of PFUD, then only you can try this surgery. Thank you.
Thank you, sir. Sir, my doubt is why worldwide it is not utilized this facility, even though it is invasive. Why we are not able to use for everyone?
So first we'll discuss about the free graft in the ileum. See, it depends upon the patients where depends on the patients. So see, for example, in our area, bit notching is endemic and oral cavity is very, very bad. So we cannot use the buccal in many of the patients. These patients have pan-urethral stricture. So for this reason only we tried ileum. So as far as ileum is concerned, we are the first to demonstrate, and our period of studies were almost 15 years. Coming to the vascular segment, in patients with long urethral stricture, the main option is one is permanent perineal ureterostomy. Second option is we can try preputial tube flap, preputial tube to reconstruct urethra. This is second option. Third option is only enterouretroplasty. Doing permanent perineal ureteroplasty in patients with PFD is very, very difficult. So that is one reason. Suppose we take reconstruction of urethra with using the preputial tube. There also the complications like dribbling of urine, divertical formation, all those things are happening. Another important factor is in patients with circumcised patients, you cannot use the preputial tube. So in those patients, bowel is better. I will not say bowel is not without complication. Definitely bowel is having its own complications. But when there is no other option, you can try, keep it these things in mind, you can try.
What about the among the results? Uroflowmetry, how it is it, sir?
The uroflowmetry usually around 13, something like that. But how we assess the patient is
You have
will
never
be
you have never operated again any of the patient who are you are, if you are to do dilatation at the rings, have you done any intervention in post-operatively or during follow-up?
sir, in the ileum mucosal cases, a free graft, almost we have 4 or 5 failures. These failures happened in the initial period of our learning curve. Now, in some patients, they will fail. The failure mainly happens in the meatal region. So the failure happens in the meatal region. It is mainly because of the disease, that is BXO. So even if you do erythroplasty, always take care of the BXO part, and these patients should be followed up for lifelong. If the BXO is active, we'll be giving some tacrolimus ointment and vitamin D substitution, all these things. If you combine both these things, results are good. And
Can
the
we do
graft uptake,
laparoscopically in this patient? Can we do laparoscopically mobilization of these segments and then put through the anastomosis? Can we do it?
we can do it, sir. We can do it. But I not done it. You can do it.
Yeah. I mean, just thinking it will be minimally invasive. Stapler can be used and you can bring the fragment intracorporeal suturing. It will be less invasive to the patient. That's why I'm asking.
Yes, sir, we can do easily in the
sigmoid
stomach.
column,
We can
in
usually
sigmoid column,
de-intest.
when you take in
Yes, sir.
sigmoid column, when you take the mesentery, you will do end-to-end anastomosis, or you will take a flap like it is not possible not to take a gastroplasty type. You have to do end-to-end.
Yes, always end-to-end, sir. End-to-end.
And
End-to-end, we'll be taking a segment of sigmoid. But only problem in the sigmoid is the sigmoid should be like almost S-shaped and mobile. Then only we can bring the segment down. In some patients, the sigmoid is very straight. We cannot do the surgery. So always when it go
last when you have done this type of surgery, which year? In this year you have done, last year like that?
last year, sir, last year.
So now also, if you don't have buccal mucosa, you will see the sigmoid and take up the case.
Sir, if the buccal cavity is not suitable, we prefer ileum, not sigmoid. My choice is always ileum because very easy to harvest. And second, the bowel complications are very, very minimal in small bowel and compared to a large bowel. So anybody can use ileum very easily.
Small bowel tube is better. Small bowel mucosal graft is better.
For the inflammatory stricture, small bowel mucosa is easy to harvest. For the long segment stricture, we can try first option is sigmoid. Second option is ileum. Third option is stomach.
So there will be a lot of patients who will be coming in failure cases. If the buccal mucosa is healing very well, after how many months or years you can retake the buccal mucosa?
So within 1 year we have done that actually. Within 1 year we have done. But the problem is, when you take repeated buccal mucosa, definition these patients, the oral cavity is going for fibrosis, and these patients will be having problem. There will be difficulty in swallowing, and the salivary flow will be difficult. So repeated buccal mucosal graft is not advisable. Definitely these patients will have their own problem.
Okay, sir, this is something interesting which I don't have much knowledge, but you are the only person in India who is doing it. I think you should come out with paper published, and definitely if nothing is available, any mucosal and tube is or graft is better. And I don't know, because of the invasiveness, world is not accepting this, and you should be doing, even if buccal mucosa is present, you should compare with 10 cases buccal mucosa and 10 cases intestinal mucosa. I think at least 10-15 cases, long follow-up will be better. Thank you very much, sir. Great. It is